Well, good morning, everyone. Welcome to today's session of Grand Rounds. My name is Dave Hemmendinger. I'm the Chief Information Officer for Brown Medicine, and I will be your Zoom moderator for this morning. Before we start today's session, a couple of housekeeping items. Please be reminded to mute your microphones as well as your video during the presentation. This will help to mitigate and minimize distractions to the presenters. Secondly, we'll be taking questions via the Zoom chat function. The Zoom chat function can be found at the top or the bottom of your screen, depending on how your Zoom screen is laid out. And as always, this presentation is being recorded and will be available for viewing on the Lifespan Media site sometime tomorrow afternoon. Without further ado, I'd like to hand it over to Dr. Rice to start today's session.
Thanks, David. Good morning, everybody, and welcome to another weekly Grand Rounds. This is a very special week for us in the year. This is the week we honor the research efforts of folks in our department, but particularly the work of our internal medicine trainees. I think, as we all know, research is a major focus of our department. It constitutes one of the three legs of our mission to provide superb patient care, educate the next generation of providers, and to advance medical science, which is what we're going to be hearing about today. As always, high-quality research is a group effort, and I would sincerely like to thank all of the faculty who have contributed their time and their knowledge to mentoring our residents in some of the work that you're going to hear about today. In particular, as always, I'd like to thank Dom Tamaro for his enthusiastic support of promoting research among our residents, and particularly to Phil Chan and Matt Murphy for their support and guidance of the residents in doing their research and encouragement. And finally, to Bharat Ramratnam for his visionary guidance of research within the department as a whole, which is truly thriving. And finally, I'd like to thank our three presenters, Anshul, Wasik, and Aaron, who you'll be hearing from shortly. And lastly, I just want to remind everybody that Thursday is our Department of Medicine Research Day, where you will be a Nobel laureate will be speaking to us at 4 o'clock. Then 3 more residents will be presenting their work from 5 to 6. In addition, if you go to the website, you will be able to see the posters of the other residents who've done research. Unfortunately, given the pandemic, we can't do this in person, but please go visit the posters, make comments, and congratulate the residents on their work. So without any further delay, I would like to hand it over to Phil Chan to make the introductions. Phil?
Great, thank you, Lou. Thank you for the kind words and words of wisdom. I want to thank everyone for attending today. I'm just going to also thank a few people behind the scenes who really helped today, as well as resident research in general. I'd like to start off by acknowledging Matt Murphy, who's leading our resident research track, and he's been helping behind the scenes a lot with resident research in general. Chief Sarah Rhodes, thank you, Sarah. You've been invaluable for facilitating everything related to resident research. It has definitely not gone unnoticed. Luis, who's the administrative person behind the scenes, who's making everything go, as well as Alex Mayer, who's also been very supportive. And the residency directors and leadership, including Dom, for everything they do related to resident research. The biostatistical core has really been a key part for a lot of residents in making things go. And all the faculty mentors, I know a lot of you are on the call today. Thank you all for your support of resident research. Obviously, that's critical for their success. Thank you for being available, for being accessible, and for help guiding them. None of us underestimate that for sure. And finally, the residents. It's tough enough to complete a research project in a normal year of clinical training. So for all you residents who are listening, and for those not, thank you. Great job in general, especially given that there's an ongoing pandemic. It's always tough to choose the best research project for presentation. I was optimistic and thrilled this year that we were able to choose 6. So there's always a significant number that are it's just tough to choose from. So what we did this year is we chose 6, and above and beyond the usual 3 that we did. So 3 are going to be presented today, 3 at the Department of Medicine Research Forum on Thursday. So please attend that. And as a reminder, we chose the 6 based on scientific rigor, time and investment, interest in general to a general medicine audience, as well as a range of different type of projects. We tried to mix it up. So, for example, that all projects were not from cardiology per se. We tried to get a nice mix of different topics. So sit back and enjoy. I'd like to introduce the first presenter, Erin Baroni, PGY4. The title of her presentation is Ask Me Who I Am, Improving Care for LGBTQ+ Youth. So Erin, if you're there, feel free to share your presentation and let's get started.
Yeah, thank you so much for the introduction, Dr. Chan, and thank you for helping put this together, as well as Dr. Murphy, Dr. Rhodes, a lot of the thank yous that you gave out. I share the same, and yes, this is definitely not a presentation on cardiology, so just beware. But like you just said, the name of my presentation is Ask Me Who I Am, Improving Care for LGBTQ+ Youth. And I hope throughout the presentation, despite talking to an audience of internists, that you will see that this information, does hold weight for our adult population as well. So I have no financial disclosures or conflicts of interest with the information in my presentation. And some quick objectives: briefly define some pertinent terminology and vocabulary that's a part of this study, introduce Youth Pride Inc., which was the motivation behind the project, describe some hypotheses that we had at the beginning and that helped determine the structure of our study, review findings of the survey and implications for future care, and pose ways that we as providers can potentially improve data collection and therefore healthcare for LGBTQ+ communities. So just very briefly, vocabulary, we all know it, LGBTQIA, etc. There's a lot of letters, there's a lot to know, but I want to go through just quickly some that I will reference during this presentation. One, sexual and gender minorities is considered a more inclusive term to describe LGBTQ+ community, so I may use it as I'm speaking broadly about the community. Cisgender means your sex assigned at birth aligns with your gender identity, whereas transgender means your sex assigned at birth is incongruent with one's gender identity and typically the other binary gender, so male or female. Versus gender diverse or non-binary is one's gender identity does not conform to either male or female, which are considered the binary identities. And then lastly, the term SOGI, which means sexual orientation and gender identity, is typically used in discussions in terms of gathering better electronic medical record data. And overall, I think that the most important thing is to just realize that these are spectrums and there are a lot of vocabulary terms and there's a lot of identities. But at the end of the day, everybody's on a spectrum. It's everybody's personal journey with their gender identity expression and sexual orientation. And so if you feel overwhelmed by all the letters, I always reference back to this. So to get a little bit more into the study, Youth Pride Inc. is a fantastic organization here in the community. It's a nonprofit that serves as a safe space for LGBTQ+ youth. And my colleague and I had the opportunity to experience this as a part of our advocacy rotation. And after spending time there, we felt implored to apply for a CATCH grant, which is a part of the American Academy of Pediatrics, to do a community outreach project, which is really what this is focused on. But while we were there, we put together a focus group, about 20 kids, and asked them questions about their experiences with healthcare in the community and what it was like to see a doctor. And so some of the responses we got: I've never seen my doctor without my parent in the room. That was a 17-year-old. My doctor has never asked about my pronouns, a 14-year-old. Should your doctor look down there every time? Which is an important question for some youth or people who experience dysphoria with their body. And what's a prostate? I didn't even know I had one of them, from an 18-year-old who was really interested in their anatomy and knowing more about their body. So we had a couple hypotheses after this focus group. One was LGBTQ+ youth often identify in categories represented by the plus in the LGBT+ or LGBTQ+ rather than the L, G, B, or T. And also, we assumed that they probably do not feel safe discussing their sexual orientation and or gender identity with their provider. So we came up with a needs assessment, 16-question red cap survey that we had a little QR code, had the kids fill out at Youth Pride, gathered some demographic information, age, race, sexual orientation, and gender identity, although those are kind of open-ended questions. assessed comfort level with provider and a couple of different questions with a Likert scale. And then we obtained some qualitative data with open-ended questions. So for the demographics, we ended up having about 40 kids. Age range was 14 to 22 years old. So some people that you may actually even see at the CPC. 25% were white. Actually won't explain all of that, but we had a good racial and ethnic kind of mix in terms of the group that we had. And surprisingly, 56% had actually seen a doctor or a provider in the last year, which we did not expect, given that youth are not as great about going to the doctor every year. So for our first hypothesis, that LGBTQ plus youth often identify as something other than the LGB or T, we did find that, 61% in terms of gender identity did identify as cisgender, but 39% identified as something else. So whether that was transgender, gender nonconforming, two-spirit, which I didn't define before, but is an identity common in the Native American community, and then other. And so I think this has important implications for how we are talking to our patients and how we're thinking about this. And similarly for sexual orientation, I only outlined here that something else was actually the majority for youth, which was 33%, and the other categories, just for those who may not be able to see, were lesbian or gay, straight or heterosexual or bisexual. But again, the majority identified as something else, which could encompass pansexual, gynosexual. There's a lot of different terminology that's used. And so I think it's important to ask what those terms mean to people, just as an aside. So hypothesis number 2, we assume they do not feel safe discussing SOGI or sexual orientation and gender identity with their provider. So 42% felt not very comfortable or neutral talking about it, and 44% felt uncomfortable or not very comfortable talking about their gender identity, which obviously is a significant portion. Granted, this population, some of which are plugged into providers that are actually specialized in gender care. So this actually may even overestimate the comfort level of the youth. And some of the qualitative data, so to kind of just give some anecdotes and blurbs again, we asked the youth to just give suggestions for ways that providers could better address these topics. And some of the things they said: ask preferred name rather than pronouns, because pronouns really are personal pronouns and people really prefer you use their name. Explain why asking this information matters to a doctor. If you misgender someone, apologize and try to learn. And then when there's a rainbow on the door, on a badge, it makes everybody feel more comfortable, which of course I love to see, given I have rainbow on me all the time. But a little bit of optimism from the data we collected. Youth do seem to desire improved relationships with healthcare providers. So despite the fact that a lot, 44% hadn't been seen without a parent after the age of 12, which for all the internists, at 12 is typically when we start to see kids without a parent in the room for some portion of the exam. 93% would prefer it, and they could have chose neutral. So they actually would prefer to really have that one-on-one time with the provider. And then 83%, despite being uncomfortable for almost half the participants, still feel comfortable with their provider overall. So I think there's a lot of room to work with there in terms of building relationships. And then just to hit the point home, Rhode Island statistics, about 1.4 million adults in the United States, so not Rhode Island, identify as transgender. In Rhode Island, about 4,000 people ages 18 to 64, Mass 30,000 people, Connecticut 12,000. And just for comparison, there's about 30,000 people with cystic fibrosis in the United States, and MEN syndromes, which get taught to us very frequently in medical school, 0.003% of the population. So this is a big portion of people you could potentially be taking care of, and this is just for the transgender community. And even some stuff in Rhode Island, so 20% of Rhode Island high school students are identifying as gender expansive, and that doesn't include people who are identifying as transgender. So this also applies, I didn't include it here, to sexual orientation. It's just, this is going to become your patient population. So to kind of round out everything, going forward in terms of gathering better data to better gather data to improve research for these communities. There we go. You can actually do this in Epic. You can click somebody's gender and you can input their sexual orientation. You can also put in their gender identity, but I want to warn, please do not use transgender female, like male to female or female to male, which some people may want to do, so that they kind of know which organs a patient has or things that may have implications for their healthcare, but this can potentially out somebody who has transitioned, especially legally transitioned. So I warn you, you can kind of like look at it, and if you have questions, feel free to ask, but just please don't use that. There's actually on the next slide an organ inventory if you're concerned about making sure somebody still has a uterus, etc. And lastly, there's tons of resources. I'm not going to go into each one, but there's a lot here for you to learn. And even our own Annals of Internal Medicine just came out with a fantastic paper about taking care of trans patients last year. And then we actually have our own awesome open door clinic. It's an LGBTQ plus clinic here in Rhode Island that Phil Chan and Matt Murphy both work at. So in conclusion, significant ongoing healthcare disparities for LGBTQ plus communities, need for improved provider relationships, importance of addressing deficits in our own graduate medical education, multiple avenues to implement change. And I do personally believe primary care providers are responsible and knowledgeable about trans and gender diverse care, doing hormone therapy, pre-exposure prophylaxis, post-exposure prophylaxis, and unique needs of these communities. And thank you to all the lovely people that I worked with, especially Youth Pride and the staff there. Sorry if that was over time.
Thank you so much, Erin. That was wonderful. And, you know, I think your project really, just on a side note, I think your project really embodies more what's needed in medicine in general, which is engaging both community organizations. Youth Pride has been around forever. They do a lot of good work over on the west-south side of Providence. Just engaging communities to address health disparities. As we know, there's a lot of populations that are at higher risk for multiple health outcomes, including COVID. And I think one thing that struck me in your presentation was that only 25% of your participants were white, which means 75% identified as non-white. And really only 56% of this higher risk population had seen a provider recently. So I'll start off by asking the first question here. If people have any other questions, feel free to put them in the chat. But how do you think, without singling out, you know, a single clinical entity, but how do you think we as a healthcare system in Rhode Island are doing in general when it comes to the LGBTQ plus population? Are inpatient, outpatient services, do you think they're adequate? Is there anything we can do, any low hanging fruits to make it even better?
Yeah, I think that's an excellent question. Thank you, Dr. Chan. You know, I think Rhode Island is doing well. I don't know if I can give a specific, but you know, the Department of Health actually has a sexual orientation, gender identity kind of group, a lot of resources that are listed on the Department of Health website, which is unique. We have a dedicated clinic that opened this last year, which I think is fantastic. I will say from my own personal experience and just conversations with patients, I do think we are still very much lacking in our primary care providers' knowledge in terms of taking care of this community and just asking the questions, and then much less being able to prescribe PrEP and PEP, some of the most important, I think, primary care things, as well as hormone therapy. You know, I think that we could do better with that, and I think we could do better with education here in Rhode Island. And so I think we have excellent things going, but there's definitely room for improvement.
Great. Well, thank you so much, Erin. I don't see any further questions, but thank you very much for your presentation.
Thank you.
We're all virtually clapping. The next presenter I'd like to introduce is Anshul. Anshul has done a lot of work this past year. I've done some work with him myself. He's going to present today on predicting permanent pacemaker implementation in patients undergoing transcatheter aortic valve replacement, TAVR, utilizing a shallow feed forward neural network. So thank you, Anshul, and take it away.
All right, thank you so much, Dr. Chan. Good morning, everyone. My name is Anshul Parulkar. A word of warning, this presentation is focused loosely on cardiology concepts, but it's more focused on the topic of artificial neural networks. And as Dr. Chan mentioned, my topic here today is predicting permanent pacemaker implantation in patients undergoing TAVR, or transcatheter aortic valve replacement, utilizing something called a shallow feed-forward neural network. So first, I have no disclosures to state. So I have two real objectives in this talk today. And the first, of course, is to review the backgrounds, methods, and results of my project. But the second is to provide an introduction to the very broad topic of AI and its applications to medicine. Now, I'll preface this by saying that artificial intelligence is an immensely vast topic, and one that I'm very passionate about. And this talk is meant to be just an appetizer. So first, some background. The minimally invasive aortic valve replacement procedure known as TAVR was FDA approved in 2011, and since then, volumes have increased significantly. So it's quite a common procedure today. One of the adverse events that we sometimes see after this procedure is conduction disease. And this can be severe enough to sometimes require a pacemaker implantation after the procedure. The estimated incidence of this is about 8.8 to 14.6%. Now, predictive models are great tools. They can actually help in identifying patients before the procedure who might be at risk for this complication. Our objective in this study was to look at various statistical techniques to predict post-TAVR pacemaker implantation. And we explored one such statistical technique called a neural network to predict this outcome. So stepping back a second, why explore artificial intelligence at all? And what is AI? Well, AI, or machine intelligence, as it's more commonly known, is broadly thought of as the ability of a machine to replicate human cognition and problem solving. And this may seem like a fairly futuristic concept. It may seem relatively new age, but it might surprise you to learn that the field is actually fairly old. It was originally founded in 1955. And since that time, the interest in the field and research funding to the field has somewhat ebbed and flowed. In fact, there was this period back in the 80s and 90s called the AI winter, where there wasn't as much interest in the field. Although recently, over the past 10 years, as we've seen microchips developed, as we've seen computing power grow, there's been a lot more interest. And AI today is an extremely diverse field. There's multiple subfields within AI that are very interesting, such as human reasoning, knowledge representation, something called natural language processing, which plays into electronic medical record data quite well, and then, of course, image perception. And there's significant applications of AI to medical research, and in particular in building these enhanced predictive models that can help make sense of diverse and complex data elements, as you might find in a healthcare database. So this is a picture of IBM Watson. It's a famous supercomputer that was developed by IBM, and it's known primarily for its natural language processing chops. And so what it does is it's really good at these large unstructured databases that have a lot of text, so electronic medical records, but it's also quite good at playing board games. It's beaten a couple grandmasters. So what are artificial neural networks? ANNs are powerful data processing tools that are originally inspired by our brains and by the neurons that connect our brains. So essentially, they're just really powerful software programs that are designed to take in information from the environment and pass it through a series of nodes, which I like to think of as filters, to make that data more interpretable. The data is transformed node to node using complex mathematical functions. And in this way, neural networks can be used to analyze patterns within large and complicated data sets, which contain multiple parameters. Oftentimes, these data elements don't even have to correlate with one another. So next, I'm going to attempt to take you through the anatomy of a neural network. Now, stepping back, if you look at that block in the lower left-hand column, you or I might look at that and see a tube. But what a software program sees when it looks at that is just a collection of pixels, which are differently colored. So how does a software program look at that image and decide that that's a tube? Well, the whole goal of a software program, such as a neural network, is to take that image and generate a series of probability distributions, which it then applies to known existing integers, which are the red circles all the way on the right, that it might determine, all right, well, this is the probability that what I'm seeing is a 2 and not a 3, 4, or 6. So the first thing it does is it takes apart that image and turns it into a series of pixels. And each pixel is assigned a number based on the grayscale. So on one hand, you have a totally white pixel. On the other, you have a totally black pixel. And then you have gray in between. And all of that numerical information is stored in this three-dimensional stacked matrix. And then what the program does is it takes that three-dimensional matrix and flattens it into an n/1 matrix using various filters. So what are filters? Well, you might think of a filter in this case as being some quality inherent to the number 2. So for instance, maybe there's an arch on that 2 that is inherent to a 2 and not a 3. Maybe there's a little tail on that 2 that's inherent to a 2. Maybe there's a loop that's inherent to a 2. And all of those filters will allow the the program to generate a series of probabilities that will then be able to tell it, well, there's a 98% chance this is a 2 and not a 3, 4, or 6. It's the same concept as, let's say someone walks into the ER with chest pain. How do we determine that patient has a myocardial infarction? Well, we start introducing filters of our own. We generate, what is the troponin? What is the EKG? What is the clinical presentation? What is the natriuretic peptide level? So it's analogous to the way we think. That's a loose analogy. So what did we do? So we used MATLAB to construct an artificial neural network of our own to predict pacemaker implantation post-TAVR. We began by building a database of 514 patients here at Rhode Island Hospital. We looked at 41 clinical variables, and this ran the gamut from demographics to echo parameters to procedural details and complications. We then partitioned that data into 3 sets. So a training set, which was made to build the algorithm, the validation set, which is used to tune the parameters of the algorithm, and then the testing set, which is used to measure performance. We defined our network architecture, so this is why it's a shallow network. We chose 10 neurons or filters in total, and then cycle times, which shows why it's a feed-forward network. That is, it progresses sequentially through the data. We selected our training algorithm, and we finally generated performance metrics. So this is the first performance metric that we generated. It's something called the confusion matrix. Now, the point of this matrix is not to make you confused. This is really just a way to represent the performance of the algorithm. So if you look up at the left box at the top, that is the training data. That's how the algorithm performed on the training data. And on the x-axis, you see the 0 and 1. That represents the performance of the algorithm for the primary outcome, 1 being pacemaker implantation and 0 being no pacemaker implantation. So on the x-axis, that is the defined outputs from the data. The y-axis represents the algorithm defined outputs. And what you see is that the algorithm was able to predict with 75% accuracy that patients got a pacemaker after TAVR. However, it was far better at predicting whether patients would not receive a pacemaker after the procedure. And that carried through for the validation and the testing cohorts. So next we generated ROC curves. So a receiver operating characteristic curve is just another measure of a model's ability to predict an outcome over and above random chance. What we do is we measure the area underneath these curves, and that gives us a sense of the ability of a model to discriminate from random in predicting whatever outcome we want to measure. So here you see that our model had about 50 to 55% area under the ROC curve, meaning it had a modest but positive discriminatory ability to predict our outcome. Next, we generated an error histogram. So this is just another way to examine the error of the model and its ability to deviate from a true value. So right in the middle of the chart, you see a yellow bar, and that's the 0 error bar. And on the x-axis are all of the deviations from that 0 error bar. The y-axis are all the instances or the measurements that the model was taking. So our model had a negative bias, which meant it tended to predict 0 over a 1. That is consistent with the confusion matrix that we just presented. And finally, we generated a cross-entropy curve. So a cross-entropy is just another measure of error. And the whole goal of a model is to reduce cross-entropy within the data set as much as possible. And one of the ways it does this is by cycling through the data, that is looking at the data again and again. And you might think the more you do this, the lower the cross-entropy. But that's actually not true. There's this concept, which I can't get into today, called overfitting, where a model that is really good at predicting the data in one data set might not be able to be applied to other data sets. And so in this model, we were able to achieve the optimal set of parameters after only 6 cycles, and we gave it 12. So what did we learn from this project? First, we learned that we were successfully able to actually build and implement a basic neural network to predict this outcome with modest performance in a small population. One of the chief limitations of our project was that we had a small data set and we had very few positive outcomes to work with. So one of the ways to improve performance in artificial intelligence is to have large data sets with many more positive cases. We also learned that artificial neural networks are themselves highly powerful tools. They have multiple applications to medical database research in particular. And in my opinion, I think that neural networks and other machine learning algorithms are our statistical allies as we enter this era of ever expanding and increasingly complicated medical data, which will be coming to us real time. So finally, I'd like to acknowledge all my fantastic co-authors. We were actually fortunate to be able to present this work this past weekend at the American College of Cardiology's virtual scientific sessions. Thank you very much.
Great, thank you so much, Anshul. Fantastic work. I will also start out asking the first question. Again, if people have any questions, please do enter them in the chat. So, Anshul, based on your reading and your knowledge of this subject, let me ask you a question. You showed that your model was about 75% sensitive in terms of the outcome. And from my reading, it seems like that's about on par with how neural networks generally do, 75, 80, maybe even as high as 90. Haven't seen any certainly higher than that. But what are your thoughts on how AI may be integrated into medicine? You mentioned that this field has been around forever. I'm not aware of any commonly used models of AI in medicine. I'm sure it's used behind the scenes, if you will. It's used for a lot of financial models and whatnot. But are you aware of any hard examples of how it's being used currently in medicine or where it's going to go? And of course, the biggest question on everyone's mind is, will we ever be replaced by AI?
So the short answer is no. I don't think we'll be replaced by AI at all, but I do think that it's going to impact medicine in a number of ways. So there's a saying that good AI is AI that you don't really know about. It works in the background and it helps improve processes and make them more efficient. So in medicine, it's already being used. So for instance, in certain imaging programs, so for instance, in echocardiography, there are ways of estimating certain dimensions and things of that nature using AI algorithms that happen in the background. It's used a lot in identifying risk. So if you look at large data sets, primarily insurance data sets or payer data sets, you can identify patients that are at risk, and that's, you're absolutely right, used more for financial purposes these days, but it can also be used for medical purposes by physicians in building predictive models. But I think what's challenging about AI is that it's a completely different field. It's not one that we in medicine were trained in. And so understanding its implications and understanding how to implement it, especially in real time when we enter this world of wearable technologies and real-time medicine, point of care medicine, I think that is going to be a challenge. And that's going to be something I'm interested to kind of witness as I progress through my career.
Thank you, Anshul. And there is one additional question for you here. Can neural networks suggest additional variables that should be considered, or do they have to be known beforehand?
So that's a great question. So the type of neural network that we used was a supervised learning algorithm. So we inputted all the variables that we thought would be of interest. What we didn't tell the neural network was how to make sense of those variables and what the actual cocktail was, what the probability weights were for the variables that we used. But currently, I'm not aware of a way in which a neural network might suggest additional variables, but there is this whole area called unsupervised machine learning, where you input a lot of raw data and a neural network might be able to tell you things about patients or select phenotypes of those patients that you didn't identify. So that's an active area of research right now.
Great. Unsupervised machine learning sounds like the precursor to Skynet. But one additional question for you from the audience. Can you comment a little bit more on how the filters, the quote filters, are determined? Is it that the work of the creator, the builders of the neural network, or are they pre-created?
So they're not pre-created. So this is what's kind of scary, but also fascinating about neural networks. The neural network itself determines the filters. So if you give it the inputs and give it the outputs that you're looking at, so for instance, in my example, you have a list of integers that you're giving it, it will determine the filters on its own through a process of trial and error. And there's been a lot of interest in that because a lot of folks who criticize artificial intelligence think that there's a black box nature to some of these algorithms where you don't really know how they're coming up with filters and what the inputs are. So that's another area of active research, is uncovering that black box nature.
Great. Well, thank you, Anshul. That seems to be all the questions. Thank you so much.
Thank you.
Actually, do you have another question? Sorry.
Oh.
There's one more. So are there planned next steps for exploring other data sets? if you could talk a little bit more about. where you go from here.
Absolutely. So I'm going to be fortunate to be here as a cardiology fellow with my good friend Wasik, who's presenting next. This is an area of interest for both of us, and there are a lot of other projects that we have planned.
Great, thank you so much.
Thank you.
And so on that theme, and again, it just so happened that there were 2 projects this year which warranted an oral presentation on machine learning. Wasik Sheikh is going to present to us on a similar topic, similar but different. Coarse decision trees have a high sensitivity in predicting post-operative atrial fibrillation in patients undergoing CABG. Insight from machine learning from the Society of Thoracic Surgeons database at a single institution. So Wasik, take it away.
Thanks, Dr. Chan. And so, yeah, so my project is kind of in the similar vein as Anshul's. I'm going to be talking about decision trees and predicting post-op AFib after CABG. I don't have any disclosures, so I'm going to go straight into the background here. So new onset post-operative atrial fibrillation after CABG is actually pretty common. A lot of studies have shown that the range can be anywhere from like 10 to 40%. And as with regular atrial fibrillation, you have an increased risk of morbidity and mortality, and that's really no different with post-op AFib after CABG. Increased risk of morbidity and mortality, renal failure, longer ICU times, which translates to increased resource utilization and overall hospital length of stay. And obviously that translates to costs to the healthcare system. And so conservative estimates have actually put it at about $2 billion of extra costs. So, you know, obviously this could be an area of interest in trying to predict new onset atrial fibrillation after CABG. And actually, interestingly, it's remained quite a challenge. So there are a number of scoring systems that have tried to predict postoperative atrial fibrillation. So for instance, there's actually a POAF score that's been looked at, and it's kind of like a scoring system based on age, LVEF, and there's also, if you can even ask the question, you know, we use CHADS-VASc all the time to risk stratify folks for stroke with AFib, and they've actually used CHADS-VASc as a means to predict postoperative atrial fibrillation. And initially, in the initial studies, they actually do pretty well, but then when you apply them to kind of test sets, the actual accuracy ends up being 0.5 to 0.6, maybe slightly greater than 0.6 in studies. So it's still a pretty big challenge in trying to predict this. And so, as Anshul just gave you an excellent talk about machine learning, I'm going to talk a little bit about it as well. So machine learning has kind of been an active area of interest, at least in the last couple of years in medicine. Predominantly, a lot of studies have come out in the realm of imaging, where you'll have echo algorithms for echocardiograms as well as EKGs. But machine learning can actually be split into supervised and unsupervised machine learning. And so the way I think about it is basically supervised machine learning is when you know the outcome of interest. So in our case, postoperative atrial fibrillation. And then unsupervised, where you don't know the outcome of interest, but you're trying to cluster your data into groups. And so common supervised learning algorithms include k-nearest neighbors, logistic regression, kernelized support vector machines, and random forests. And we've actually investigated all of these with postoperative atrial fibrillation, but for this talk, I'm going to be talking about random forests. And so what random forests are, is I'm sure all of you kind of looked at up-to-date algorithms where they kind of ask you a question where it's like, does the patient have this? And then it splits into yes or no. And then I ask you another question, and that splits. And it keeps splitting until you ultimately get to a decision. And so what a random forest is actually a collection of decision trees. And so basically the algorithm will generate multiple trees and basically majority rules and making a decision of whether or not this person will get postoperative atrial fibrillation or not. So we tried to investigate that with patients who underwent CABG at our institution at Rhode Island Hospital between the years of 2014 to 2017. And we used the STS database, which is the surgeon's database. And we actually excluded patients who had a previous history of atrial fibrillation and flutter. And we use basically demographic data, pre-op data, which includes comorbidities, their pre-op hemoglobin, pre-op platelets, intra-op data, which includes intra-op hemoglobin, the number of bypasses, bypass time. And so these were all imported into Python, standardized, and any missing data was actually imputed. And basically we split the data set into training and test sets, 80% and 20%. And we did what was called a stratified 5-fold cross-validation that was run on the training set and then applied to the test set. I'm going to spend a little bit of time explaining to you what a 5-fold cross-validation is, because I think that is the crux of machine learning, at least with supervised machine learning. And Anshul actually alluded to this when he was talking to you about overfitting. And so what a 5-fold cross-validation is actually a technique to prevent overfitting. So theoretically in machine learning, you can actually tune a data set, tune a algorithm to actually be 100% accurate at predicting your outcome of interest. But the problem is that it can be so tuned to that one data set that it absolutely fails at a test set. And so what a 5-fold cross-validation is in a way to keep the algorithm honest and give you sort of an accurate representation of its predictive ability. So on the top here, you can see the training set split and the test set split. And so what happens is in the training set, so I said 5-fold. So basically the algorithm splits your training set into 5 separate pieces. And so it will run on 4 of them. It'll train on 4 of those splits, which are the black boxes. And then it will validate it within the test set with that other fold. And so that's the one fold cross-validation that is done. And then it will do that, but then it will shift what's the validation data and what's the training data, all within the training set. And then so you average that together and you kind of get an estimate of its actual true performance. And so then your algorithm's like optimized, and then you can actually apply it to your test set to evaluate its predictive ability. So here's some of our results. So we ultimately ended up having 472 total patients in this data set. We had about 206 just predictors that we put into the algorithm. The incidence of postoperative atrial fibrillation was 33.94%, which is on par with the literature. Median age was 67, 22% women, 89.5% Caucasian. About half had diabetes, 38% had heart failure, and almost 100%, 98.8% was their first cardiovascular surgery. 93% were on beta blockers within 24 hours of the OR, and the mean BMI was 29. And so fortunately, Anshul kind of already gave you all the details about what this is. So this is a confusion matrix. And so our predictive ability here, so this is the predictive ability of the algorithm, and this is the actual true class. So this is correct prediction, and this is correct prediction, and everything in red is incorrect. And so you can do that both on the training set, and you can actually do that on the test set as well, as kind of a measure of how well your algorithm does. And so for us, our AUC for the test set actually ended up being 0.73, which was its accuracy. The sensitivity for predicting postoperative atrial fibrillation was 85%. However, our specificity was only 32%. Our positive predictive value was 72%, and our negative predictive value was 50%. And so conclusions that we take away from this is that, predicting postoperative atrial fibrillation is still a pretty big challenge. Random forests do provide decent sensitivity and accuracy for detecting it. And just to give you a little bit of perspective, there was a recent paper in the American Thoracic Society that actually looked at all the scoring models and compared it to a logistic regression model using only age as a predictor, and found that one scoring model that had an AUC of 0.68, which is the Charge AF score, had the best sensitivity, and all of the other models were actually no better than the model that was a logistic regression model of only age. So I think algorithm performance is limited by your data. And so there's a mantra in machine learning that garbage in is garbage out. And so I'm not saying that, the STS database is garbage, but what matters is whether or not the variables in your data set correlate with your outcome of interest. And it could be that the variables that are included in the STS database, which is not designed to predict postoperative atrial fibrillation, are not correlated to that outcome of interest. And obviously the drawbacks of this is it's a single center study. And as we kind of talked about in Anshul's talk, implementing machine learning algorithms in the EMRs, in healthcare still kind of remains a challenge. It's kind of uncharted territory. And so that ends my talk, and I just want to acknowledge all these good folks who have been on our journey in exploring machine learning.
Great job, Wasik. Thank you so much for that presentation. A couple questions in the chat. I'm just gonna ask here. So, question from Dr. Rice: how do the machine learning algorithms deal with the notorious inaccuracy of much of the EMR in terms of copy and pasting? Do these algorithms mostly stick to labs and other reliable data?
Yeah, so at least for my project, this was all reliable data. So this was all basically things that could have been binarized or just continuous numbers. So for instance, platelet count, hemoglobin, bypass time, comorbidities. There's a whole other field that's investigating sort of natural language processing within the EMR. So there are a lot of studies that can actually use some of these algorithms to parse through EMR data and actually terms within people's notes to try to predict things as well. But that wasn't really the focus of my project per se, but there's certainly techniques that are utilized to actually go through textual data. But that, for my project, that wasn't the focus.
Wonderful. Second question here from Dr. Murphy. Are there ways to calibrate algorithms to address data sets that may not be representative of the more general population?
So yeah, so there's actually, that's a great question. So there's a lot of techniques. So one thing I didn't go into is a lot of these algorithms have tunable parameters. So for instance, for random forests, you can control the number of trees that are actually within that the algorithm uses. You can control the number of splits, you can control the number of nodes. And if you can imagine, you can loop this as many times as you would like and train it on the data set and optimize kind of the tuning parameters. So you can actually tune a lot from that end. And then, for instance, there's other techniques that you can use. For instance, say, if you're trying to predict something that's in the minority class. So for example, if you have email and you're trying to say, I want to try to predict spam, and spam might be only 1% of your total emails, there are actually techniques that you can use to artificially boost that data point within the data set itself so that the algorithm can train on that to try to predict your outcome of interest better, even though it's in the minority. And we're actually kind of looking at that as well. There's also another way where you can kind of figure out the best combination of variables. So there's a technique called recursive feature elimination, where you can tell the algorithm basically to look at all the combinations of variables, then calculate an AUC, and now subtract one of those variables, now calculate the AUC, and then it will basically optimize and figure out the right combination of variables to get you to maximize either sensitivity, AUC, whatever outcome of interest you're looking for.
It's interesting, as you and Anshul were both talking about all these modelings, I was thinking about some of the way that modeling was being used during the COVID pandemic. Just an FYI behind the scenes, the state has a whole modeling team, and there's a lot of decisions during the pandemic that have been based on modeling in general. And by the way, if any of you have followed some of the national modeling for COVID, it's basically all been wrong. So I'm just curious, as you and Anshul were talking, in terms of thinking about typical statistical modeling and epidemiological modeling, what machine learning, how does that, is it better? Is it going to replace model? How do you think, what are the benefits of this sort of approach over typical statistical modeling?
Yeah, so that's a great question. So there was actually a recent, I think it was in JAMA or New England, I'm blanking on the actual journal, but there was an article actually out that was assessing sort of supervised machine learning compared to our regular statistical modeling. And to be quite frank, it hasn't really panned out that well. A lot of these supervised machine learning algorithms also seem to not do that much better. So the way I kind of view it is, I think it's an additional toolkit in our toolbox that is kind of a technique that we can use to try to see if we can better predict our outcomes of interest. But I also think it's an important kind of task for us as healthcare providers to try to come up with data sets that we think may actually be helpful in correlating what we're trying to predict. So a lot of these algorithms are using pre-existing data sets that already exist in the world. So STS, NRD, NIS. And so I think crafting useful data sets remains a challenge. And I think that is kind of the way forward. And you know, if we create data sets where a lot of those variables are actually correlated with our outcome of interest, or at least theoretically are correlated with our outcome of interest, we may find that a lot of these machine learning algorithms may perform better than standard statistical techniques. But currently, comparatively, they don't do much better.
Great, thank you for that. That's all the questions that we have for today. So I'll turn it, Dr. Rice, I'm not sure if you have any final words of wisdom here, but thank you, everyone. Thank you to our residents for presenting and everyone for attending.
Thank you very much, Phil. And I want to thank all of the presenters. These were 3 fascinating presentations. The artificial intelligence is truly remarkable, and it'll be interesting to see exactly how far it can get us. And I was really particularly impressed by Aaron's presentation on an area where I think we all have an awful lot to learn, and that there's a whole population out there that we may well be underserving. So I look forward to all of the really smart people in computers doing the computer learning, but you know, I think that Aaron's presentation will be a good call for us to really expand how well we care for patients who aren't in the quote norm. But thank you to all 3 residents. These were terrific. And thank everybody for attending. David?
Thank you, Lou, and thank you to all of our presenters today. 3 great presentations. Again, as a reminder, this session has been recorded and will be available on the Lifespan Media site sometime tomorrow afternoon. So again, everyone, thank you for everything that you do. Have a wonderful day, and we'll see you next week at Grand Rounds. Bye now.